I welcome Afrin to give an introduction speech about our moderator and the presenter. Afrin, over to you.
Yeah, ma'am. Good afternoon to one and all present here. And it's my immense pleasure to introduce Ms. VE Tharaniy, ma'am, who currently serves as an assistant professor in the Department of Optometry at the School of Health Science, Institute of Technology and Science. Ms. Tharaniy brings with her over 1 year, 7 months of academic and clinical experience and is deeply committed to shaping the next generation of optometry professionals. She completed her undergraduate degree BSc Optometry in Mugavari Eye Hospital, affiliated with Bharatiyar University, Coimbatore, and she completed her postgraduate degree, Masters in Optometry from SRM University, Katangulatur. Her core areas of interest include low vision, binocular vision, and contact lens fields, in which she continues to explore, learn, and contribute through both teaching and practice. Please join me in welcoming Ms. Dharani, ma'am. Over to you, ma'am.
Yeah, thank you. Thank you so much, ma'am. It's a great intro. Hi, good afternoon, everybody. So now we can enter into the section, ma'am.
Yes, ma'am, we can start.
Yeah. Ms. Pushpa will be presenting the case. Pushpa, is it audible for you?
Yes, ma'am.
Yeah, okay. I'll just share the screen. Is my screen is audible? Is my screen is visible for everyone?
Yes, ma'am.
Yes, ma'am, it is visible.
Yeah, over to you, Ms. Pushpalatha.
Good afternoon to everyone. Myself, Pushpalatha from Hindustan Institute of Technology and Science. I'm presenting a case based on a neuronal ceroid lipofuscinosis. Ma'am, shall I on my video or is it okay?
Yeah, it's fine. It's fine.
Okay. Ma'am, the next slide, please. Ma'am. Sorry, na tapani.
Hari Shankar, can you mute yourself?
So this is the patient history.
Is visible now?
Yeah. Yes, ma'am. The patient history is the 13 years old female who came with the referral from the neurological department from NIPMED hospital with the diagnosis of retinal degeneration and for treating vision. Ma'am, can I have the next slide? Her previous ocular history was both eyes, a complete blind history of complete blindness since the year 2022 after a seizure for the first time. History of difficulty of vision and using prescribed glasses since 2018 and she dropped because of some betterment. And the history of vision therapy consultation. The history of students studying in the blind school since 2023 and a negative history, that means a no history of any ocular trauma or surgery. The birth history of the child is a type of delivery is C-section delivery, cesarean, and the delivery month is full term. The birth weight is normal of about 1.5 kg. The milestone and the Apgar score is also normal. The systemic history of the patient is a history of seizure for the first time in the year of 2022, history of slurring and the repeated speech, which means echocholia, without answering after the seizure, which means a patient can only hear the speech but can't answer to the speech. And the history of bradyarrhythmia, which is called as an irregular heartbeat since the year of 22 after the seizure, and also the poor muscular movement, which is called as ataxia since the same year, and also the conduction abnormalities the patient has since the year of 7. History of constipation due to gastrointestinal dysfunction in sometimes like on and off, and history of enhanced water consumption and excessive urine secretion to more than 10 times per day. The family history. Family history is negative consanguinity of marriage. Her mother and father were not consanguinities, and the father family history of her uncle has the same condition of CLN3, and this was told by the patient's mother. The family history of brother also having an albinism since 3 years. Medication history. History of under medication for seizure since from 2 years, like from 2022. History of using antiarrhythmic medications for above 5 years. E and vitamin B supplements for 5 years above. History of using trehalose medication for reduction of lysosomal storage. The recent investigations are not assigned, and the allergic history they are not aware. The pupils, as a patient is completely blind, she can't able to. The patient is not reacting to the light, and the visual acuity is it gives a negative perception of light, and the objective and the subjective refraction is not done because of the patient is uncooperative. In the investigation, the first comes slit lamp. It gives the anterior segment all normal. The upper lid and lashes are normal. Conjunctiva is normal in both eyes. Cornea is in both eyes are clear. Iris is normal. Lower lashes and lid are normal. Anterior chamber depth is grade 4, and the lens is totally clear. In the fundus, with the 90 diopters, with the 90D lens, in both eyes, there was a pale disc, arteriolar attenuation with thin retinal vessels, peripheral retinal pigmentary changes, and also a parafoveal hyperpigmentation, which is consistent with the bullseye maculopathy. Then here comes the optical coherence topography. Thinning of outer retina, which is due to the loss of photoreceptors, and macular disorganization is also present. Electroretinogram. This is also a diagnosis which investigation which was taken part. The test was full field electroretinography. The findings were scotopic response, cone response, and 30 hertz flicker response, and overall impression. In the scotopic rod response, severely reduced amplitude and the delayed implicit time. In the photopic, it is moderately reduced but prolonged implicit time. Rod is delayed implicit and the photopic is prolonged implicit. The 30 Hz flicker response was at almost it was extinguished. And overall impression were dysfunction with the rod cone involvement, and it is consistent with Ceroid lipofuscinosis. Next slide. Here comes the blood test again. The sample called peripheral blood with the ADTA tube. Routine blood test, the hemoglobin level was 13.5 mgdl. White blood cells per cells, and the platelets were 4 lakh, and the smear was presence of occasional vasculated lymphocytes, and the metabolic screen was normal. In the genetic test, mutation detected in CLN3 gene. The variant was homozygous 1.02 kb deletion, and the interpretation was pathogenic mutation consistent with a juvenile neuronal ceroid lipofuscinosis. And here comes the diagnosis. In both eyes, it has retinitis pigmentosa, retinal degeneration, and in the systemic and neuronal sides, we have the neuronal ceroid lipofuscinosis and this epilepsy, which is called a seizure, and also we have a mental retardment. So here's the case of basic juvenile neuronal ceroid lipofuscinosis. In this case, ceroid lipofuscinosis, it is also termed as a juvenile Batten disease. This CLN3 case works on the accumulation of lipopigments in the neurons and either other tissues. And the CLN3 is an autosomal recessive disorder in which the parents remain as carrier and one of their child gets affected with this neurodegenerative condition. It usually occurs in the age of 4 to 10 years, often between 4 to 7 years due to the CLN3 gene mutations. This disorder affects the body's ability to get rid of the cellular waste like lipids and proteins so that they build upon the cells all over the body. There is no cure for this Batten disease. The risk factors of CLN3 case is the genetic mutation, autosomal recessive inheritance, consanguinity, and the family history of Batten disease. The pathogenesis of this condition is if the CLN3 defective mutative protein is there, it will first affect the lysosome, it will first dysfunction the lysosomes and then accumulate in the ceroid lipofuscin, and then the cellular dysfunction becomes, and hence it is traveled to the neurological, ophthalmological, and systemic effects. So these three can get it. The classification is based on the age of onset, based on the gene mutation, and based on the clinical features. By age of the onset, congenital, it is termed as congenital, infantile, late infantile, juvenile, late juvenile, and adult. By the gene mutation, the congenital has CLN10, the infantile has CLN1, late infantile has CLN2, 5, 6, 7, and 8, and the juvenile has CLN3. The late juvenile has variant forms of CLN conditions, and the adult only has CLN4. By the clinical features, we have ophthalmic, neurological, and systemic effects. These are the symptoms of which I have classified into ophthalmic, neurological, and systemic. The ophthalmic effects are like progressive vision loss, photophobia, which is sensitive to light, and nyctalopia, which is like sensitive to the night vision, and the nystagmus, dichromatopsia, which is the difficulty to see colors, and the loss of contrast sensitivity, and metamorphosia. The neurological effects comes as the seizures, dementia, depression. Dysphagia is nothing but a difficulty in swallowing, and dementia is nothing but a difficulty of a person to think, a tremor, hallucination, and anxiety. The systemic effects comes with the bradyarrhythmia. As I said, it's irregular heartbeat, sleep disturbances, insomnia, weight loss, immobility, malnutrition, and they have a reduced lifespan. The clinical evaluation for this CLN3 condition with the fundus examination will start it. The bull's eye maculopathy will be seen, optic disc will be pallar, attenuated retinal vessels, RPE atrophy, retinal pigmented epithelium atrophy, retinal dysfunction in the electroretinogram, epileptiform discharges in the electroencephalogram, brain cerebral and cerebellar atrophy in the magnetic resonance imaging, and the neuroexamination shows ataxia, dystonia, and the Parkinsonism features, and the ECG shows the bradyarrhythmia and the AV block. Optical coherence tomography, it shows the retinal thinning, retinal pigmented epithelial cells loss, and macula thinning. The investigations will have electroencephalogram, which have the epileptiform discharges like a spike wave or a polyspike, seizures, and it shows the abnormal brain activity. Electroretinogram shows rod and cone responses. In the early time, it shows the reduced cone and rod responses, and the late it cannot be it cannot be recordable. It is extinguished. And the CT scan shows the cerebral and cerebellar atrophy. The magnetic resonance imaging shows the cortical thinning and cerebral atrophy. Cerebellar atrophy, especially in the vermis, and the white matter changes in the advanced stages of CLN3. The blood test shows the routine labs were usually normal. The genetic testing were diagnostic, and the enzyme assays was not specific for only CLN3. Visual evoked potentials in CLN3 was delayed P100 latency, which is slow visual conduction, and the reduced amplitude of responses, and it indicates a severe optic nerve and retinal pathway dysfunction. No detectable VEP responses, which is consistent with the complete blindness. The management for this ceroid neuronal lipofuscinosis was to control the seizure. Was the initial step. To control the seizure, we take off anti-epileptic drugs like valproate, levetiracetam, and lamotrigine. To avoid drugs that worsens myoclonus like carbamazepine and phenytoin. Visual rehabilitation, which includes low vision aids in only the early stage, orientation and mobility after the complete blindness, and the supportive for blindness, which includes the braille and assistive technologies. Like we can use like smart vision glasses for the low vision mobility training. Motor symptoms like physiotherapy, which helps in mobility, and occupational therapy, which reduces the contractures. The cognitive and psychiatric management. The special education and memory training can be given. The medications for mood disorders like SSRIs for depression and antipsychotics, and the behavioral therapy can be given in according to the psychiatric management. Feeding and nutrition. Here comes the dietary modifications, thickened fluids for dysphagia because the patients wouldn't be able to swallow everything that much quick. So the thickened fluids for is better for them, and the feeding tubes in the late stages to prevent the aspiration. Cardiac care is important, regular ECG echocardiogram monitoring, and the pacemaker implantation if in there are severe bradyarrhythmias or AV blocks are there. Here is a final summary. Hence, the CLN3 is a rare autosomal recessive neurodegenerative condition which is caused by the mutations in CLN3 gene. In this condition, genetic counseling plays a vital role in by guiding the families about inheritance patterns, recurring risk, and options like career testing, and prenatal diagnosis. Since there is no curative treatment available, care is mainly supportive. Rehabilitation, which includes physiotherapy, occupational therapy, speech therapy, along with the psychological guidance, will be more helpful for them to at least live their life a bit longer till the a symptomatic management which addresses the seizures, cardiac issues, and nutritional needs is important for their lifetime. Therefore, a genetic counseling with the combined multidisciplinary rehabilitation helps in the management of ceroid lipofuscinosis, which is neuronal. Thank you. Thank you, everyone.
Thank you, Pushpalatha, for bringing to our notice a very rare and cases like juvenile ceroid lipofuscinosis. Thank you so much for bringing to our notice. And I would like to hand over to Ms. Tharaniy ma'am for moderating the session now.
Yeah, it's a good presentation, Ms. Pushpalatha. Hope everyone has understood this case. Do you have any other doubts in this case? If anything, you can post it here. So actually, this juvenile, it is also shortly called as Batten disease or neuronal steroidal lipofuscinosis, where there is a new cure. The symptoms usually starts in the childhood days, and the person will be having it will be the seizure, And next, they will be having the progressive vision loss. That is, they will have RP and macular degeneration is the first state of retinal findings we will be seeing. So then the patient will have motor difficulty. They can't able to pick up any glasses or anything. They cannot able to hold, and they will have also the unable to walk for a shorter period of distance. Addition to this, these people will later develop into the cognitive impairment where they cannot able to, even they can't able to reply what's the question was asked by the practitioner or the doctor or by the family members. That was the main clinical features about this condition. So this juvenile NLC is a very rare, and it will be out of 1 lakh people, 2 to 4 will be affected due to the genetic causes. It is an autosomal recessive, as Ms. Pushpalatha says, it is an autosomal recessive gene, and it is mostly found in United States. And now here we can able to see these types of cases also. This patient has going for the special blind school since the 2003, and she was studying. They came for the hospital to check whether they can improve the vision or to give any other aid or any other facility in order to enhance their quality of life. That was the main motto for this patient. Then everything was done. Later, they have given some orientation and mobility training, and low vision devices that would not that much they are effective. And that was the case. We will go to the what is the neuronal NLC part. So NLC is what the primary three causes is what vision is impact, and next is the vision. Seizure brain will be affected, that leads to the seizure, that is the first initial symptom, and next will be cognitive and motor will be difficult for this patient. So what is this disease? NLC is a broad term. Everybody know about lysosome. Are you aware of lysosome? What is the role of a lysosome, or what is the function of lysosome? Anyone? Yeah, okay, fine. So lysosome is present in our cells, which is mainly useful for to fight against the waste materials or to cause the cell death or digest the cells, which is of waste. The waste cells will be digested by the lysosome. That is the main primary function of this lysosomes. So when there is a gene mutation, mutation is nothing but the changes in sudden change in the chromosomes. When there is a change in the gene, that significantly affect, that is this disease is called as CNL3. If the CNLS3 is affected, the patient will be having a lysosomal storage disorder. That means the lysosome function is to attack the or digest the waste materials in the cells. Once the mutation has been taken in the CNL3, this does not happen. That is, the lysosomal function does not occur, where the disease cannot digest where the lysosomal does not digest the waste materials. Instead of that, it start collecting the fat and the lipid proteins in the neurons. So even the neurons over a period of time, after it is accumulating proteins and fat materials, these neurons will causes the cell death. The cell death leads to certain areas of impairment. In eye, if you take, we have neurons which supply to the entire body, right? It produces the signals and it transmits the electrical signals to the brain, to the concerned targeted tissue or the structure or organ. So once this neuron as itself is dead, the information or that reaching to the brain will be affected. So in eye particularly, they will be having retinitis pigmentosa and some degenerative conditions, that is your macular degeneration will be occurring. Generally, they will be having seizure. Addition to that, all types of disease they will be having, because this lysosomes is present in the entire cells. So the entirely they will be having few more diseases. Then the patient will be having in beginning of the life stage, they will be having a delayed milestone. But in this case, the parents does not report the delayed milestone. They said it is a normal in behavior. Normally, the child has grown and he achieved the milestone, and no red flags were set by the parents. So later, milestone will be delayed, seizure will be having, and progressive vision loss, that is your RP will be having. Then coming to the main significant, the muscles will be very much weakened. due to the lysosome activity, that is storage of lysosomes. It leads to motor, they cannot able to walk, they can slip, they can fall easily. The spine will be, the spine alignment will not be in a straight manner, it will be have a cirrhosis or any type of spine modulation will be happen. Then the patient cannot able to walk. And the important thing is that the speech is also impaired for this patient. They cannot able to even reply if they had lunch. We asked if they had lunch, they cannot able to say. They will have a repetition of words only. They cannot understand because the cognition is also affected in this patients. So the classification mainly, this is the overall pathogenesis of the case. So just once again, I will give the pathogenesis. So in gene mutation will be occurring and lysosomal dysfunction will occur. Usually lysosome digests the cell's waste materials. Due to the lysosomal dysfunction, it cannot able to digest the waste material. In order to digest the waste material, it starts to accumulate the fat and lipids. So it leads to the neuron cell death. So leading to that, the neurons will be affecting in the entire body, that is your eye and other parts of it. So in eye, we specifically have RP and macular degeneration. That here it is in the condition of Bull's maculopathy. So later we will come to, we will do fundus, we will do any other test. The first we will complete the eye part. So we will do OCT, we will do fundus photography and all the things, we will find it out. And to confirm to whether the patient is having CNLC, the first thing we need to have a gene therapy, that is your gene diagnosis. You have to find out whether it is CNLC or any other thing that is causing the RP. RP can be caused at any syndromes, golden hour syndrome, any syndrome can happen. So whether it is due to that or any other syndromes are occurring. So the first is what we have to see the genetic testing, DNA testing, and then we have to analyze this, whether CNLS is affected or not. Then only we can confirm that the patient is having CNLC. So if they are having CNLC, we can give supportive drugs or supportive management only, not to the fulfillment of that therapy, because yet now it is under the research, no complete curative of this condition has been successfully found. So one is what to manage this patient, and several tests will be conducted. Example will be having, due to cardiac muscle is also where neurons is also supplied it. Here the ECG will be abnormal, brain activity will be abnormal, and all other activity will be abnormal, which is not in the normal. Coming to the management state, the patient, if I is having CNL3, mainly they will be giving that is a seizure, anti-seizure tablets. And that was the primary therapy, because seizure leads to, if over a period of time seizure occurs, it will be a immediately sudden changes can occur. So that was the first line of therapy they will be giving. Next, coming to the some of the vitamin A and vitamin E supplements will be given to the patients. Coming to the eye related, so as it is, we already know for RP, when one is the stem cell therapy is still under the process. So we will giving the orientation mobility training or any other supportive devices like audio based low vision devices, that is assistive devices, audio books or audio clocks, like that only we can able to give to them, because no any other vision can be helpful, device can be helpful for them. One is that she said smart vision glasses can be given to tell what is present in the surroundings and everything. Later we will go to what genetic counseling, that is the first prior important, because this disease, some of the disease is still under the process of research. Here we don't have any management for this patient. We will go for, if the patient or parent or mother, anyone that is having such kind of a disease, we should give genetic counseling is the first priority, because this can be the parent can be a carrier, and it can also lead the child to develop the certain diseases like this. So in order to avoid, genetic counseling is the first priority for these patients to overcome the future causes of this disease. So hope everyone has understood. Is there any doubt, or I want to elaborate in any other topics, like causes, risk factors, or any other thing?
Students, if you have any doubts, you can post your doubts in the chat box, or you can unmute and speak. If everything is good and fine, can we have a thumbs up? Can I have a thumbs up if all is clear? Am I audible? Interns, externs? Okay then. So thank you, Tharani ma'am, for this wonderful session. I again welcome Afrin for the thanking note. Afrin, over to you.
Yeah, ma'am. As we come to close of the today's session, I would like to take a moment to thank our presenter, Ms. Pushpalatha, for brief explanation of the neuronal ceroid lipofuscinosis. A sincere thanks to our moderator, Ms. VE Tharani, for being with us and for sharing her valuable time, knowledge, and experience. Her passion for teaching and practice services as an inspiration to all aspiring optometry professionals. We are truly grateful for her presence and insight she has shared with us today. Thank you once again, Ms. Tharani ma'am, and thank you all for your attentive participation. Thank you all.
Yeah, sorry, I was just want to give a time note. Thank you, Dr. Agarwal, Institute of Optometry, provided this opportunity as a moderator for this section. And thank you, Jemima ma'am and Matangi ma'am and Ritika Srinivasan, who delivered the vote of the thanks. Thank you to the entire Agarwal team.
Thank you, ma'am. Thank you so much. So thank you, interns and externs. So we will meet you all in the next Friday class session and as well as in the other case presentations. So thank you.